Okay, welcome everybody. I'm going to quickly share my screen. So welcome. Today we are going to be talking about COVID-19 vaccination in the perinatal population. Before I introduce our presenter, I'm going to share that pre-poll for those of you who were here at the last COVID-19 in the perinatal population web series. This poll, we're going to do a pre-poll and then a post-poll, and it's to assess just your level of understanding from what was presented in Dr. User's presentation. It's brief, it's short, and it will just help us for our CDC grant reporting. So let me pull that up, and if you could all take that, that would be great. It's just 9 quick questions. Thank you all for taking that quiz. Well, not a quiz, that would be a little more educational poll. Just gonna leave it open for another minute. Okay. Great. So thank you all for joining us today. Our speaker today received her doctor and PhD from the University of Vermont, also my alma mater. Dr. User then completed her residency in obstetrics and gynecology at the University of Minnesota. In 2013, Dr. User began her fellowship at the CU School of Medicine, and then in 2016, she joins the Maternity Fetal Medicine Division at the University of Colorado. Dr. User serves as the MFM division's expert in viruses during pregnancy. So please help me give a warm welcome to Dr. Anna User.
Thank you so much. As I'll get into a little bit later in my slides, there are some very personal reasons that COVID in particular has kind of been able to come up as a point of interest for myself for presentation and for patient education. So,
and Dr. User, you should be able to share your slides. Perfect.
Yep, working on it. I have boomer-esque qualities, even though I guess I'm technically Gen X or whatever, but let's see. There we go. Okay, so I know we all wish we were on vacation somewhere. So that's, I think, where I got my background from this time. So we're going to be talking today about COVID-19 in the perinatal population and specifically focusing on the importance of vaccination and what we know about the safety data, both from a maternal and a fetal neonatal standpoint. So as far as disclosures, I want to point out that many of the treatments for COVID, including some of the vaccines, have not received full FDA approval and are in use under emergency use authorizations or EUAs. I've also done my best to present updated information. However, current standards of care continue to change, and this information should be used as a guide only. Any treatment decisions should be shared decision-making between patients or their representatives and their healthcare providers. So our objectives today are to review available safety data on COVID-19 vaccine with regards to pregnancy, discuss why you may recommend one vaccine over the other, and evaluate the risks and benefits of specific vaccine timing with respect to pregnancy and postpartum considerations. So when we think about how many people are vaccinated at this point in our pandemic experience, we have data both from the United States as a whole and for Colorado. This upper panel here is the state of affairs across the country. In general, for the CDC here, these data are shown with the darker the color of blue, the higher the vaccinated proportion of the population. So this darkest blue that is here in most of New England is about 80 to 89% vaccination rate for people's greater than 5 years and older. So for the US in general, 82.1% of the US population has received at least one dose of the vaccine, and about 66% are considered fully vaccinated. When we look specifically to Colorado in this lower panel here, the data is broken up by county. Again, the darker the blue, the higher the vaccination rate. The darkest blue in this scale is actually 70% plus. So this would be the Denver metro area here, this collection of, it's very odd shaped county, and then the rectangles around it, Denver metro area. So in Colorado, about 84% of people greater than 5 years old have received at least one dose, and about 74% are fully vaccinated. So we are a little bit ahead of the national curve as far as our vaccination rates go. All this data was accurate as of 4/13/2022 when I pulled it from the CDC website. When we think about pregnancy and how many pregnant persons are vaccinated, we have a little bit more granular data from the CDC. This was also accessed on April 13th. This chart here is complicated, and I know you probably can't read these numbers across the bottom, but basically this is week by week breakdown across the time. So this last week here was the week that started with 4/9/2022. Back here we have 2020, early 2021. So about a year ago is this range here. In this graph, the lightest blue are people that are pregnant and have completed their vaccine series prior to their pregnancy. The yellow bars represent people that had the vaccine series both before and during pregnancy. And then the dark blue are those people that decided to get the vaccine series completed while they were pregnant. So as one would expect, as time has passed, more and more people have already completed their vaccination series prior to their pregnancy. And thus these light blue bars are becoming more and more predominant as the whole, as more and more predominant of a share of those patients that are vaccinated in pregnancy. 1 year ago, so this is April 24th of 2021, we had about 14% of patients were vaccinated during pregnancy, 3% before and during, and about 6% prior to pregnancy. So, and that was an overall 22.5 vaccination rate. So we have made strides in that. If you look at data from from the early part of this month, we had a 4.3% vaccination during pregnancy, 2% before and during, and 64% of our patients had already been vaccinated prior to their pregnancies, with an overall estimated rate of vaccination of 70.2%. However, it is important to note that that 70.2% vaccination rate for COVID-19 vaccine is still less vaccine coverage rates than for the other vaccines we recommend during pregnancy, such as flu and pertussis. If we break this data down a little bit more, we also have data for vaccination coverage of pregnant persons by race and ethnicity. I apologize, this graph was a little bit more blurry when I tried to import it. Basically, this top bar here in the maroon is the Asian non-Hispanic populations, and that population has an estimated vaccination rate in the beginning of April for this year of almost 90%. Overall, again, is that 70% vaccination rate. The populations that are falling under that include Black non-Hispanic patients, who are represented about 57% vaccination rate, and then Hispanic, Latino, and white non-Hispanic are both around 67-68% vaccinated. And those lines are grouping all here with the overall rate. So we have been doing better than average with our Asian populations and poorer than average with our Black non-Hispanic populations as far as vaccination rates go. I'd like to take this opportunity to go through some of the safety data that we have to date and how we've been collecting that for the COVID the COVID vaccine in pregnancy. So, of course, this all started with one of the common concerns that we hear from a lot of our patients, in that it wasn't studied in pregnancy. And to this, I typically reply, true, but we had animal data that showed no risk of teratogenicity. We didn't have those initial trials that had pregnant women in. They were in fact excluded, but several dozen were inadvertently included in the initial data collected for both the Moderna and the Pfizer vaccines. The FDA did allow administration to pregnant women starting in December of 2020 under a shared decision-making model, even though that had not been specifically studied in pregnancy. And currently there are still phase 2 and 3 trials underway specific to pregnancy. So how have we been collecting the pregnancy safety data? There were registries that were created explicitly for this purpose. And so as of the middle of April this year, this number of self-reported pregnant people vaccinated in the United States was over 218,000. And the number of those people that were in the V-Safe COVID-19 vaccine pregnancy registry, they had enrolled over 22,000 women. Those patients that are part of the registry here, the subset, they're actually contacted by phone several times during pregnancy and postpartum for additional health check-ins, both on mom and then also on baby after delivery. The registry enrollment is markedly less than the number of self-reported pregnant people vaccinated, and that's for a couple of different reasons. One, time is required for the registry staff to contact the participants who identify themselves as pregnant. Not everyone who identifies as pregnant meets the registry criteria. And the registry is only designed to enroll a certain number of vaccinated people at different time points during pregnancy. So it's going to be smaller than the number of all pregnant people's vaccinated. So this is where my role as a vaccine advocate / experimental person came in. I want to point out that professionally, I always will advise all my patients to get any beneficial medical care during pregnancy. And in my opinion, this includes all vaccines. Personally, I was pregnant during 2020 and was happily vaccinated at 32 and 35 weeks gestation. And this has provided many opportunities to share my story in hopes that patients are reassured and consider getting the vaccine themselves. And my daughter and I are actually part of the V-Safe pregnancy registry, and we're one of the completed pregnancies that were reported in the initial data that we're going to go through in a second. Part of what I've done is through the University of Colorado, we've done some print materials and also some videos that have gone out mostly to employees, but trying to be part of the campaign for being a face of vaccinated peoples during pregnancy and why I felt like it was important. And I can attest as far as the registry goes, I think I got about 3 or 4 phone calls during the pregnancy and then several contact points in the postpartum period. And I know they did request my daughter's medical records at 6 months from her pediatrician. So they are trying to build a pretty comprehensive database for the registry participants. So the initial publication of this data was published in the New England Journal of Medicine. The lead author is Shimbakuru, and it was initially published online in April of 2021 and then in print in June of 2021. So the study population were anyone that was self-identified as pregnant at the time that they received their COVID vaccination, and it was about 35,000 women total at that time. These were all peoples that had gotten the mRNA vaccine, so about half were receiving the Pfizer and about half were receiving the Moderna vaccines. Most of the people studied were between 25 and 34 years old, as one would expect for reproductive aged women, and 87% of them were pregnant at the time of vaccination. The remaining peoples were those that were probably pregnant at the time of their second vaccination or shortly after their second vaccination. The data here in this box is looking at the side effect profiles. The top 2 panels here are the Pfizer, dose 1 and dose 2. And the bottom panels are the Moderna vaccine recipients, dose 1 and dose 2. The dark blue bars are those peoples that were pregnant at the time of their vaccine, and the light blue bars are those who were non-pregnant. So what this graph is essentially showing is that there really weren't any appreciable differences in the side effect profiles between pregnant and non-pregnant persons. This was at the time point of 1 day after the shot in each case. They also, of course, included data on those us in the registry. So at that time, the registry was over almost 4,000 patients, so 3,900 patients. As one would expect, based on the timing of when this was published and when they were collecting data, most of the peoples included were healthcare personnel, because this was the first populations that were being offered vaccination. So 94% worked in healthcare, 99% were between 25 and 44 years old, and 79% were non-Hispanic white as self-reported ethnicity. Most of the doses were given in the second trimester. So this data here shows that 2% of the doses were given periconception within 30 days of the last period. 28 and 29% of the doses were given in the first trimester. 43% of the doses were given in the second trimester, and 26% were given in the third trimester. At the time that they did this publication, there were 827 completed pregnancies. Most of these were women that had been vaccinated in the third trimester, though some of these women with completed pregnancies were those that were vaccinated either periconception or early on and had an early into their pregnancy, such as a spontaneous loss. So when we look at the outcomes of completed pregnancies, live birth was 86.1%. The risk of a first trimester spontaneous loss was almost 13%, with the vast majority of those occurring less than 13 weeks. Stillbirth rate was 0.1%, and other outcomes, which would include a therapeutic termination or an ectopic pregnancy, whereas about 1%. There were 724 infants born, and 12 sets of multiples were included in this data set. What they did, of the reported congenital anomalies, none of them received the vaccination pre-conception or in the first trimester, and they didn't see any specific pattern in the anomalies that were reported. What this graph is showing here is the incidence of these outcomes in the pregnancy registry versus the published incidence. The way that this study was reported, they didn't have a control group because obviously they were just reporting that they had seen in their observational cohort. So what they did is included the published incidence for these different adverse outcomes as a comparison to see if there was any differences between historical rates of some of these complications and those that occurred in the patients that had received the vaccines. So for comparison, the 12.6 rate of spontaneous abortion in the first trimester was compared to self-reported values of 10 to 26%. The stillbirth rate historically is less than 1%. And this was dramatically less than 1% at 0.1. So that's sort of how they were comparing the initial batch of data to say, well, we didn't see any higher signals for safety concerns compared to what's historically accepted as the common rates for these things. The authors concluded with that the data did not indicate any obvious safety signals with respect to pregnancy or neonatal outcomes associated with COVID-19 vaccination in the third trimester of pregnancy, though continued monitoring is needed. And this was predominantly pointing out that we didn't have the data at this time for any of the second and first trimester vaccinations and what happened in those pregnancies. There's been a few other publications looking at vaccine safety pregnancy outcomes. So Thieler et al. Was published in the newly named Pink Journal, the AJOG MFM in 2021. This was data from Minnesota and Wisconsin that was accessed through data in EPIC. And it was collected between December of 2020 and April of 2021 and included over 2,000 women, 7% of which were vaccinated. They decided to use a composite adverse outcome index that included numerous maternal and fetal adverse outcomes. And they looked between their vaccinated and unvaccinated participants and found no difference between the groups in adverse outcomes. And it was 4.9 versus 5%. The only difference they found between their vaccinated and unvaccinated groups was the rate of COVID infection. So they had an 11% COVID infection rate in their non-vaccinated and a 1.5% rate of COVID infection in their vaccinated group. More recently, Lipkind et al. Was published in the Morbidity and Mortality Weekly Report, or MMWR, and this was published earlier in 2022. This was looking at 8 vaccine safety data linked healthcare organizations between May and October of 2021. They looked at a retrospective cohort of over 46,000 pregnant women, with 21% of them vaccinated. They found that the COVID-19 vaccination during pregnancy was not associated with either preterm birth or with small for gestational age at birth. These are both adjusted hazard ratios, and they're both less than 1, with the confidence intervals crossing 1 for each. So one of the things that patients will bring up, and I think I was even trying to figure out in the beginning, was what about all these infertility claims? So where did this even start? And this took a little bit of digging to find. There were two physician scientists who early on in the FDA kind of pipeline process for the vaccines pointed out that there was a structural similarity between the COVID-19 spike protein and a placental protein called syncytin-1. They speculated that mRNA vaccine-induced antibodies against the spike protein would also attack this placental protein. However, there was no data to support this hypothesis. And if you think about it, if there was any exposure to the spike protein that caused infertility, you would expect the same infertility concerns to happen via natural infection, which is being exposed to the spike protein on the virus itself, not just exposure to the spike protein from a vaccine. And we did not see that. There is some data also that has been collected to dispute this claim of infertility. There have been studies that have shown no difference in pregnancy success rates among women who have antibodies, either from vaccines or from a COVID-19 infection, compared to women with no antibodies. And this included even patients that were undergoing assisted reproduction technology procedures. There's also been no published differences in fecundability, which is the ability to get pregnant in any given cycle based on if somebody has antibodies or not. However, we do know that male fertility may be affected in the short term after a natural infection. However, keep in mind that male fertility can be affected by fevers from any source. And so that is something that was not surprising to find. There's also been reports of vaccination affecting menstrual cycles. So what two recent studies have seen was that they found common but minor changes after COVID-19 vaccination. And these changes included the length of the menstrual cycle, the interval between cycles, and heavier bleeding than usual. I believe, if I remember correctly, there was one report where there was about half a day difference in the cycle length after a COVID-19 vaccination. These changes were seen to be temporary. And as we know, many things can affect menstrual cycles, and this includes stress, changes in your schedule, problems with sleep, and changes in diet and exercise. And then infections can also affect menstrual cycles. So I think most of us would agree that there are many possible reasons that somebody's menstrual cycle could have changed in the last year to 2 years, and vaccination may be a small part of that, but it's likely not to the significance of anything that would change somebody's fertility or natural function. Now, in addressing some of this is Dr. Vivek Murthy, and he's a US Surgeon General. And he provided the following statement to JAMA in one of their discussions about these misinformation campaigns. What he said was, misinformation about COVID-19 vaccines impacting fertility has been one of the most persistent myths during this pandemic. Widespread misinformation has unfortunately led many people not to get vaccinated, and it has led to an alarmingly low rates of vaccination amongst pregnant people, who are actually at greater risk of adverse outcomes with COVID-19 compared with people who are not pregnant. And this is also along the lines of the statements that many of our different advisory organizations have released. So there was a joint statement released by many of these international and national societies, and it was released in December of 2020. And what they've stated is that it's incumbent upon healthcare professionals to familiarize themselves with existing trial data, including the unknowns, and to inspire confidence in the vaccine among our patients and other healthcare professionals. Healthcare professionals should continue to support efforts to collect data necessary for evidence-based recommendations. So again, there's a lot of calls for us to make sure that the information we are passing on to our patients is accurate, and to make sure that they are aware of the data that we have that does support the safety of the vaccines. So how well are these vaccines working? And when we talk about vaccine effectiveness, it's important to remember that the goal of the vaccine is to prevent severe or critical COVID-19 infections, not necessarily to prevent any infections or positive tests. So studies have shown similar immunogenicity responses in pregnant and non-pregnant persons. And what that means is there's a similar response of the immune system to the vaccine in antibody production. In the general population, the effectiveness that's reported from the vaccines is 95% for Pfizer, 94% for Moderna, and J&J vaccine of 72%. In pregnant populations, there's several studies about this. I just included two here. From Israel, Dagan et al. Published in 2021 on what they'd seen in 21,000 women. And they found that there was an effectiveness of 96% for any documented infection after completion of the COVID vaccine series. Data from here in the United States, from Louisiana, was published by Morgan et al. In 2022. They looked at over 10,000 women and showed that vaccination resulted in a 90% risk reduction for severe or critical COVID-19 infection and a 70% risk reduction for COVID of any severity. So these numbers, 90 to 96%, are on par with that reported for effectiveness across all populations. Now, breakthrough COVID is something that has come up more recently, particularly with the Omicron infections. And what this means is it's commonly defined as a positive COVID infection after your vaccination has been completed. And as I just said, it was most commonly seen here during the Omicron wave, which was in early 2022. Data from South Africa showed that the Pfizer vaccine prevented 93% of hospitalizations during the Delta wave and slightly less, 70% of hospitalizations during the Omicron wave. In South Africa, this data was without any booster doses, so just the 2-dose series. Other data does suggest that there's an increased performance of these vaccines after the 3rd booster dose, which is why that was recommended starting several months ago. This infographic is from MMWR as well as CDC, and it's, as it says here, during the emergence of the Omicron variant, being up to date with COVID-19 vaccines provided protection against infection. Adults who were unvaccinated had a 5 times higher risk of infection compared with adults who were fully vaccinated with a booster. So this topic has come up a lot, both from patients and from other providers who I've spoken with. Should I be recommending one vaccine over the others? So initially this started with the concerns of certain complications related to the J&J vaccine. So in April of last year, the USA FDA and CDC recommended a pause to the J&J vaccine due to the reports of a rare severe type of blood clot that occurred with thrombocytopenia. About 2 weeks later, they concluded that these risks were very low and the benefits of the vaccine outweighed the risks and continued use was advised. Remember that in this time period of April of last year, sometimes it was still difficult to find any vaccine appointments, or maybe you could find a vaccine appointment for one formulation versus the other. So in that time period, we did have a relative lack of doses for people. So it wasn't always necessarily easily able to get one vaccine over another. In December of last year, the CDC actually recommended that there was a clinical preference for all individuals to receive an mRNA COVID-19 vaccine, which is Pfizer or Moderna, over the J&J vaccine based on the recent evidence of the vaccine effectiveness. So that relates back to that data from several slides ago saying that the J&J vaccine was actually less effective at preventing the severe and critical illness compared to the Pfizer and Moderna vaccines. So the current recommendations are that for the mRNA vaccines, Pfizer or Moderna are preferred with a booster when eligible. So at this point, we should be recommending the Moderna or Pfizer vaccines over the J&J vaccine for all patients, and also specifically for pregnant women, because as we know, there's a slight increased risk for blood clots, and thus the J&J vaccine would potentially microscopically increase that risk. But it's more that we're recommending these vaccines based on their general effectiveness against the variants that we've seen. Then I also get from a lot of patients, well, I already had it, so I mean, I don't need to get vaccinated, right? Or I'm gonna get it anyway, I don't need to get vaccinated, I'll just get it and get my antibodies that way. Well, there's a couple reasons why vaccination is preferred. People who are sick with COVID-19 can spread the virus, so you might get other people ill if you are getting your antibodies through infection versus vaccination. Even with the side effects, vaccination has been shown to be safer than COVID-19 infection. COVID-19 infection can cause severe illness or death, even in children, and we can't reliably predict who will have mild or severe illnesses. And the COVID-19 infection can cause long-term health issues, which would be what we think about when we think of long COVID. Even people who do not have symptoms when they are initially infected can have these ongoing health problems. The CDC also recommends that even after a natural infection or having the illness, vaccination is still recommended. And this is because it's unclear what your level of protection is after an illness, because the number of antibodies your body makes is based on disease severity, your age, time from infection, and that vaccination after illness also can provide added immune protection. And so that would be additionally synergistically making more antibodies after the natural infection. So what are the benefits for the fetus and neonate? So in general, vaccine benefits are increased immunity. That's going to be increased neonatal immunity, which is resulting from transplacental passage of maternal antibodies across the placenta, which leads to passive immunity in the child. In this improved passive immunity, the response is greater after vaccination versus natural infection. So babies born to mothers who had a vaccine have been shown to have higher antibody levels than babies born to mothers who had COVID-19 illness. There's also reduced transmission of COVID to the baby if the mom and family are vaccinated. Some of this is because of the decrease in vertical transmission across the placenta that would occur if mom has been properly protected, and also decreased horizontal exposure, which would be due to close contact with a neonate by family or friends if they're infected. So when we talk about these transplacental antibodies, this is really the biggest benefit for the babies. Prabhu et al. In 2021 were able to document the earliest neonatal passive immunity was detected at 16 days after vaccine dose 1. And this figure here is from their study. So the bottom x-axis is showing the weeks that have elapsed since dose number 1. The number of mothers in a ratio that had shown antibody protection is here, and the darker blue is passive immunity. So this is showing that 18 of their patients had passive immunity or antibodies detectable in cord blood 2 weeks after the initial vaccine dose. Yang et al. In 2022 showed that there were detectable antibodies at birth in different situations, one of which was first trimester vaccination. So even in vaccination of mothers in the first trimester showed that there were still antibodies present in the cord blood at birth, and that the highest neonatal antibody levels were present when there was early third trimester vaccination. We know for both COVID and for other infections that antibody transfer occurs throughout pregnancy, but is highest in the earliest third trimester. As far as I know, this data was verbally presented at SMFM 2022, but I'm not sure if it's been published yet. And we also have seen that the highest antibody levels in the neonate are in those that received a booster dose in the third trimester. So not finishing your series in the third trimester, but the booster dose in the third trimester. Now, a lot of people will also ask about the immunity that comes from breast milk, because that is a different type of immunity. So when we talk about transplacental immunity, that is the neonatal immunity from the antibodies across the placenta, and those are largely IgG antibodies. The amount of transplacental immunity will depend strongly on the maternal concentration of specific antibodies. And as I mentioned, we know that this is highest in the third trimester, both for COVID and for other infections. For other diseases like pertussis, we specifically vaccinate during pregnancy in order to boost this maternal antibody concentration to then result in increased neonatal immunity. And so that's actually why the timing of the pertussis shot is recommended at 27 to 28 weeks, because that allows time for the maternal body to make those antibodies and for those to cross at the time that they're most effective at crossing the placenta, which is the third trimester prior to birth. When we think about breast milk-derived immunity, this comes from the secretory IgA, which is 90% of the antibodies in breast milk, and there are some smaller amounts of IgG and IgM antibodies that are present in breast milk. Breast milk IgA is not absorbed by the infant's gut, but rather it coats the mucosal surface of the intestine to protect it from pathogens. And this helps to defend mucous membranes from infection. Many studies have shown the benefit of breastfeeding for immunity. However, in these studies, it's sometimes difficult to detect if that effect is due to the breastfeeding itself or transplacental antibodies that had already passed from the mother. So when the studies were specifically looking at vaccination antibodies in breast milk, there were a couple of data that I wanted to present. From Shripe et al., this was published in the BMC Pregnancy and Childbirth Journal in 2021. Again, small study, N of 24. They had all received the Pfizer vaccine, and 14 of those 24 were lactating. They measured the titers of the COVID IgG, IgA, or IgM antibodies in both blood and milk. And what they found was that all women showed positive antibodies after vaccination. And in the blood, the IgG was dominant. And in the milk, they found modest levels of antibodies in the lactating mothers, with about half of those antibodies being IgG. So the antibodies were present, but from this data, it was unclear if it was sufficient for passive immunity through the breast milk. Another study by Golan et al. That was published in the Frontiers in Immunology in 2021, similarly small, N of 50 lactating persons who received the mRNA vaccines. They looked at blood and milk samples collected at 3 different time points: before the vaccine series, during the vaccine series, and then 4 to 10 weeks after dose number 2. They found no severe maternal or infant adverse effects were reported. And after vaccination, they found IgG and IgM were increased in maternal plasma. There was transfer of IgA and IgG antibodies to the breast milk. And the amount of IgA was inversely related to the infant age. So what that means is that in the infants that were older, there was less IgA antibodies in the breast milk. So there was a function of the body knowing how early or late that infant was, and that affected the amount of IgA antibodies in the breast milk. They did not find any IgG antibodies detected in infant blood when the vaccination was administered during lactation. And that was only 8 of their study, but still, what that means is that vaccination in the postpartum period and trying to see if that postpartum breastfeeding relationship would be enough to get antibodies to the baby is less likely based on this data. And then what about our kids less than 5 years old, of which my child's now in this group? So as we know, currently children that are 5 to 11 years old are eligible to receive the Pfizer vaccine. The trials have been underway to assess the safety and efficacy for both the Moderna and Pfizer vaccines for those less than 5 years old. Pfizer initially filed an application with the FDA for this youngest group on February 1st of 2022, and then the FDA panel vote was postponed. Since then, I'm not aware of any further movement either in Pfizer amending their application or resubmitting it, or for the Moderna trials to be submitting their applications to the FDA. So at this time point, we still don't have a vaccine that we can give to children between 6 months old and 5 years old in order to protect them directly. And so this is where there's some data, in part what I've already presented, shows that maternal vaccination during pregnancy could lead up to detectable antibodies levels up to at least 6 months of life. I'm not sure of studies that have tested it out past 6 months of life, but that may be one of our few strategies to try to get these kiddos a little bit of protection. Again, I'm not personally aware of any data that breastfeeding relationships that are going into years 2 and 3 of life are enough to be providing any of that antibody support that would be sufficient for protection. It's just not clear yet. So a couple counseling notes regarding this vaccine timing and pregnancy based on the data we have to this point. So sometimes people sort of think about trying to game the system. Like, well, if I'm gonna get it during pregnancy, then I wanna get it when I get the most benefits. So I'm gonna get it in the 3rd trimester or the 1st trimester, et cetera. So one problem with this strategy is that women don't know at what gestational age they would deliver. So if you're trying to time a 3rd trimester dose in order to maximize the benefit for those transplacental antibodies, it's possible you could wait too long and not get the benefit for mom or baby if there's an occurrence of a preterm delivery. It's also possible that 1st trimester vaccination is going to be better because they've been able to show that full vaccination, so receiving both doses in the 1st trimester, had a higher maternal and neonatal antibody levels compared to partial vaccination in the 3rd trimester, so only getting 1 of 2 doses. So the other thing to say is, well, it's better to get it as a complete series, no matter when you get it in pregnancy, versus only completing a partial series. The infant antibody levels that were found to be were higher after vaccination compared to natural infection. So again, excuse me, this comes back to the mothers that are saying, oh, I already had it during pregnancy. I don't need to get the vaccine because my baby's already protected. Well, yes, but we could probably up that protection even more with a vaccination. And finally, just to leave you with a few take-home points. The COVID-19 vaccines were developed using science that has been around for decades. These vaccines are safe and much safer than getting COVID-19 as an illness. The COVID-19 vaccines are effective at preventing severe illness and limiting the spread of the virus. And currently, vaccination during pregnancy is the only strategy for passive immunity in the youngest populations. This was me getting my booster dose, and I figured that my daughter had been there for my first 2 doses in utero, so it was only fitting that she'd come with me for my 3rd booster dose that I got last fall. And then I think this sign that was up when I was getting my booster dose really hit home, and that, really it's a population level decision that we're making when we're talking about vaccination, and getting vaccinated can help make both ourselves but everyone safer. If people have questions that don't feel comfortable asking today or come up later, I can always be reached at my email here. And then as always, the MFM team at university is always happy to do consults, and we're available 24/7 and can be reached through the University of Colorado Hospital doc line. And at this point, I'm happy to take any additional questions, any thoughts people have about these data, and we'll go from there.
Thank you so much, Dr. User. That was an incredibly informative presentation. That blew my expectations away. So thank you so much. There are a few questions in the chat that I'm seeing. So I'll read these, and then if anyone else, you can chat it in, or you can raise your hand and I'll take you off mute. But the first one, let me just make sure that you didn't answer it already, but
I think I'm looking at it too, so I can just
the one from Christine.
Yeah, so anything you would add to help support families with young girls who are hesitant to have them vaccinated due to concerns over possible infertility, early onset of menstruation, or other reproductive issues. To my knowledge, none of this is data-driven concern. And so I think trying to bring the family back to, where have you heard this? What source is it? Because a lot of these things are, oh, I heard it on the internet, or a friend told me, and trying to really redirect to what their concern is and where it's coming from, and hopefully do our best as trusted partners in healthcare to reassure them that to this point, we don't have evidence of those changes or concerns, and that getting COVID itself can cause concerns. And so while the severe illness in COVID is still very rare, it is still more common than side effects that are critical. And so I think really trying to point out to the family that some of these concerns may not be coming from reliable, trusted sources may help in that. Otherwise, I think what sometimes happens is people are just sort of trying to find a reason to say why they don't want to get the vaccine because they have their own reasons. And so sometimes that isn't prone to being redirected. And so they may come up with other things. And so I've tried to, if I sense that, I've tried to just say, okay, well, I think it's a good idea. If you want to rediscuss it at some point, I'm always happy to rediscuss it, so that you're not losing that rapport that you may have with the family over this one issue. Breastfeeding moms, the same. I feel like it's very helpful at this point. I don't think that we can tell them that they're increasing their baby's immunity by getting the vaccine during breastfeeding time period. But I do think you can reassure them that there's no negative effects that have been reported, and that you're decreasing the risk of that child getting it from a horizontal infection from close contact with the mother or other family members if they became positive. You're welcome to share this recording and any of the data. I've tried to make sure the sources were all in there so that we can get that, really focus people on the data directly. So
we have one person raising their hand, so let me take them off mute.
Okay.
Hold on. I have to find them. Oh, did you lower your hand? I can't find you anymore. Okay, I'll go to the other question in the Q&A. So it says, what if patients have been fully vaccinated and boosted prior to pregnancy? Should we be recommending a booster at 28 weeks or earlier?
So personally, I think this is where things will go. It's not an official recommendation at this point. The only person that I've personally recommended a second booster to right now is someone that is immune compromised because of medications that they're taking for one of their other health concerns, and they are pregnant. And so this patient, I did recommend to get her second booster based on her immune compromised state in addition to the pregnancy. I honestly think, in my own humble opinion, that is not sanctioned by any healthcare entities to date, but I think it's going to turn into, as we talk about pertussis every year in the every pregnancy in the third trimester, we might start to look at COVID as one of those. So every pregnancy, we're trying to make sure people are up to date on their flu, up to date on their pertussis, and up to date on their COVID booster. So I think that's probably where this may evolve to, but that is not an official recommendation right now. And so right now, outside of people that are specifically immunocompromised for reasons other than the pregnancy, I'm not recommending a second booster currently.
And there's two questions that just came in the chat. The first one says, can you discuss the difference between the unvaccinated patient who has had COVID-19 versus the vaccinated patient who has not completed their third or fourth upcoming booster?
So I'm not 100% certain on specific numbers for this situation, but my understanding of the data is that the unvaccinated patient who's had a natural infection, in most cases, will have less antibodies persistent over time than patients who have completed the full series. And I believe it's going to get a little mixed in the studies there about if someone has had a pretty severe natural infection versus someone who has not completed their series. Those may be comparable level of antibodies. However, it's important to remember with the antibody status that any one person is going to be unique in how their body and their immune system reacts to this. So these are general trends, but for any one person, it's going to be hard to predict exactly where they would fall on that spectrum. But if someone has had COVID-19 before, we do think that additional vaccine will help them, but I can't necessarily tell you what your percent protection is if you're an unvaccinated person who got it versus someone who has not completed their series.
Great. And then the last question in the chat right now is, do you know how many maternal deaths related to COVID-19 in Colorado? And what were potential barriers in the group or community level to prevent these deaths? I don't know if you know that answer, but
I only personally am involved somewhat with the cases at university. I don't believe we had any maternal deaths that were attributed to COVID only, but that is just my recollection. It looks like there was a comment from Katie Breen saying that from the MMRC could speak to this. I don't know that we have that data fully collected, but I think in general, potential barriers to vaccination rates, we do know that there's a difference in the vaccination rates by ethnicity. And I think that there are some particular concerns for some of those communities that feel that they have been either misled by medical professionals in their own personal past or in their collective history past, and so have a little bit less trust of the medical profession and providers at baseline. I think there is a little bit more of just kind of general distrust of some of these issues in different populations. And that's where I think really trying to make it a point to address it with everybody is important, because then you're doing it as a consistent thing with all of your patients, as opposed to only when you remember or only for someone that you think needs it, or other things that can creep in as unconscious bias in our own care that we give our patients.
Yeah. I know that like Katie was saying, that the maternal mortality review committee is going to be publishing soon for the period of the beginning of COVID-19 pandemic. So that should be published, I believe, this year, but I could be wrong.
Yes, I believe they'll have preliminary data out before the end of June, but I could be wrong about that.
Yeah, but that should include that. And then there's another question from, there's more. Allison asked, do you have resources for providers to assist them with conveying the importance and the risk if not vaccinated to patients? I have some experience where a provider asked about a vaccination but never followed up, and the pregnant person never got vaccinated and then got COVID. She reported that she never sensed urgency from the provider or if there was any risks.
So I think that, one good resource for all of us is ACOG, and ACOG has continued to update their frequently asked questions portion of their website throughout this time period. There is some guidance for patient counseling on there. There's also SMFM has similarly sponsored some statements as well about counseling points. I think that many of us sometimes don't want to poke a bear. And so if we bring it up, we maybe don't bring it up super strongly because we don't know where that patient lies on the spectrum of wanting, not wanting, very not wanting to talk about it. And so I think, that may be where some people don't always feel that they get driven in the importance of it. I know a patient that also, meant to get vaccinated, just didn't get around to it and ended up being incredibly sick in the hospital and happy to share their story. And so I think the other point for all of us to remember and try to get a hold to patients is that while these most recent waves have seemed to be less severe, we still don't know who's going to get really sick versus not. And that's a pretty big set of dice to roll when you're talking about your overall health when there is a vaccine available. So I think sort of trying to come at it from that point of we don't know who's going to get really sick. And so it's important for everybody to talk about it. And then sometimes the other strategy I use is I say, are you open to hearing about the vaccine? And if there's someone that it's going to become an issue and they're not, they'll just say no. And then you can move on and continue to your discussions about their other issues. And so that way, the people that are open to the discussion, you have a little bit more time to focus on that with them. I think there's another question here saying, what's your 1-minute elevator speech to the patient who's distrustful of the CDC? I think that this sometimes comes from deeper issues. In general, I want them to understand that we've all been making the best recommendations we can with the information we have at the time as we've gone through this pandemic. And so in sometimes the recommendations are going to change somewhat based on changing information. And that doesn't mean that the initial recommendations were wrong. It just means that we've gotten new or different information. And so we're adapting to it. I think in general, pregnant people are very hesitant to take anything during pregnancy or do anything that may be different. And that's where I think both, my own personal experiences or those of others who, I don't know a single OB or MFM that I personally know who was pregnant during this time period who chose not to get the vaccine. So I think, feel free to use, I know this MFM who did it when she was pregnant, feel free to use those examples if you don't have closer ones to yourself. But I think that really does help them see that even in the light of changing recommendations or incomplete information, vaccines are safe and we use them all the time in pregnancy. And this is just one more example of that, how we use vaccines to keep mom and baby safe.
Great. Thank you for sharing, Dr. User. I just wanted to thank you again for coming today and sharing all this information. I think the data is really helpful to see. So thank you. And I know you can't hear the audience, but imagine them clapping. I'm now going to share my screen. And for this presentation, SCL Health is kindly providing nursing continuing education credits. So you can use your phone and you can take a picture of this QR code, which will provide you with a website that you can type in your information. If you don't happen to have a smartphone or access to it at this time, feel free to email us at info@cpcqc.org, and we'd be happy to connect you with the folks at SCL Health. Thank you for putting that in the chat, Katie. While that is happening, I'm also just going to pull up that post poll that I was talking about. This one's even shorter. So if you could answer that, that would be phenomenal. And you can drag it away if it's in front of your QR code as well. But thank you again for coming today. We really appreciate hearing all your questions, and we look forward to hopefully seeing you at the next COVID-19 in the perinatal population webinar, which will be taking place in June. We will be hearing about vaccine hesitancy. So that should be a great presentation. So again, thank you so much, Dr. User. We loved hearing from you. And we hope everyone has a great rest of your day after you finish this post survey.
Thanks, everybody. Take care.